organization model for post-acute providers such as home health providers. This is presented by Healthcare Synergy, the same sponsor that we had for the rest of the series. And today we're going to follow up on some of the concepts that we discussed on week 1 about the accountable care organization model. Again, my name is Arnie Cisneros, and I am a home health and post-acute consultant. I work across the Medicare care continuum based on 30 years experience in the home care model, but also in 30 years experience on the post-acute venue. So this week we want to comment on something that is that has occurred since last week. And now we might point out that we last week announced that we are an ACO post-acute bundling consultant for the DMC Pioneer ACO awardee. And then since we spoke a week ago, the DMC has been awarded the Model 2 Bundling Pilot Demonstration Project for the bundling care model that the DMC hired HHSM to help them develop. So the Model 2 Bundling, post-acute and bundling services for 30 days for hospital readmissions was approved by Medicare for the DMC, containing many of the concepts that we discuss here on these webinars, specifically and including utilization review to determine exactly what our patients require and how we can deliver that in the most cost-efficient manner. So today we'll not only be talking about ACOs, but we'll be talking about the bundling element of the ACOs for home health providers. And literally, it's important to understand we are speaking from the tip of the spear to the CMS is awarding the DMC the Model 2 Bundling Award. So remember what we're talking about that we are heading towards. And I want to make sure that everybody on the line today understands that these are not just buzzwords. These are elements that are going to change home health services from where we've been to where we are going to be. So as you move forward under these elements, you're going to need to reflect back on these topics to make sure that you understand how I'm relating these concepts to actual care protocols that we're going to utilize in the future. Increased efficiencies. Just want to make sure everybody understands this. If today we take 10 visits to stabilize a CHF patient, under ACOs and bundling, we'll be expected to do that in 5 or 6 visits. If today we see 12 visits for a total joint replacement, under ACOs and bundling, you'll be expected to do that in 5.2 visits as an average. So we expect an improved level of efficiency from this care model, and anybody who's listening that doesn't think that that's a road they're going to be on is going to find themselves mistaken. Increased populations, meaning you will have more patients coming at you faster, and they're going to be resolved faster through the increased efficiency. So you've got to take a look at this. Programs will be shorter. There will be more programs, but they will be shorter in duration and in focus. Shorter programs are coming your way. They have been relevant at each and every care site that has had our patients before us, hospitals, inpatient rehab floors, long-term acute care hospitals, skilled nursing facilities. So when you think, well, we decreased our visits, well, we decreased the visits, but we didn't decrease the program. And that's really something that we're going to have to focus under the new ACO model. Fees for outcomes. So let's talk about this. The key is to deliver outcomes at a more efficient pace under the accountable care organization model. So the question is, or potentially is, how many visits will it take you to teach new medications? Well, if you're teaching a caregiver, today we might teach 4 caregivers in 4 visits. Today, in the future, will you teach 4 caregivers in 4 visits because the fees that you're charging for those outcomes are significantly greater than if you were able to gather all 4 of those caregivers or 3 of those caregivers together and handle it in 1 visit. And I think that is the best example of how ACOs are going to be expecting post-acute providers to work. And then last, the private pay component. So if you have a private pay element to your agency, certainly that would be an area that you may want to focus on, because these patients and their care needs are not going away. They are just not going to be covered by Medicare in the future. And anybody who scoffs at that concept, again, I would propose to you the assisted living system across America. Over 100,000 private pay assisted living beds for seniors that did not exist 30 years ago. Now, the accountable care organizations are certainly here to stay, and the element that we're going to be discussing a lot, but separately from that, is the discharge element, the post-acute bundling component. And we described these items topically last week, very specific about the ACO, which will be a hospital, a health system, or a group of doctors that take over the care costs of patients, and they are accountable. That's where the name comes from. The doctors, the health system, or the hospital will be accountable for the care costs of the patients that they have on their program. And in being accountable, they will have to make sure they manage care costs as they move across the episode, and that means the hospital, the lab, the x-ray, the SNF, the home health agency. And the element about discharging those patients from acute care episodes and managing them through the ACO is going to be called post-acute bundling, in which all the post-acute services are bundled for the health system, and the health system is responsible for them financially. Now, let's talk about the ACOs with regards to provider involvement. What potential for participation exists? How should you get started? What types of things should you be looking for and thinking about? What are the requirements? Where can you begin now? How does this work? How should you be thinking about this? And we're going to talk very specifically about this from the ACO and the bundling perspective, because that's who I've been working with for the past year, are the people who are putting together bundles. And as I pointed out, Medicare's Innovation Center just chose our care program as a pilot for this demonstration project. So providers' involvement, what is your potential for participation? Well, if we go back to the slides that we discussed a second ago, and we talk, are you prepared to deliver increased efficiency? Which means, can you talk to your nurses and your therapists about what they're doing, and can you find ways for them to do it at a more efficient manner? Are you able to control your clinical content and staff so that you can manage increased populations that are going to come on program and off program in a shorter episode than we see today? Are you prepared to rewire your clinicians to focus on making things happen efficiently so that you can get paid? If you are not prepared for that, then you are probably do not have much potential to participate in the ACO model that we're talking about. Philosophical requirements are necessary. You need to be able to understand that finding ways to get people better faster is how this system is going to work. And you need to be able to understand that if a patient can get better and stabilized in 6 nursing visits, that spending 8 nursing visits to do that is exactly what the ACO seeks to avoid. In 2009, both Medicare and National Association of Homecare stated that each nursing visit costs $250 a visit to deliver. So if we gave 8 extra visits to deliver, if we gave 8 total visits or 2 extra visits to deliver the care required, then we would be wasting $500. And that $500 is going to show up on the ledger of the hospital or the ACO that discharged the patient. So you've got to understand we've got to look at things differently if we're going to make things work. Many times, non-compliant patients in home care or semi-compliant patients in home care are continued so that we can reach their goals at some point, despite the fact that their compliance has lagged behind where we have where we would like. And the question is are you going to be able to turn those patients compliant and get them better quicker? So these philosophical requirements are going to be necessary. I cannot overstate how important this is. There are many good clinicians in the PPS era to date that will struggle at the beginning to internalize these philosophical requirements. Most providers that I talk to, if I ask them to give me the name of one nurse or therapist that works for them whose primary concern was to make sure that they protect their own individual visit total on their schedule, most providers would tell me the name of their clinician that fits that description without stuttering. That will betray any sort of ACO involvement if you can't manage your clinical staff. So it's important to understand that these clinical management requirements are about Part A patients. Part A patients that came out of the hospital and are going to need focus. This is how you are first going to connect to ACOs. If you get Part A patients, we'll talk later this afternoon, that is where your focus should start. Nursing philosophies are required. Are we here to provide visits, or are we here to stabilize and create outcomes? This is an element that has dogged basically home health through the PPS era. And one of the things that we point out that they have little, if any, experience of managing their own care content or length of stay in any job outside of home care under the PPS era. They didn't do it in hospitals. They didn't do it in nursing homes. And that's where the exposure lies for the potential post-acute providers. Secondly, the therapy philosophies and concerns. So let's talk about this. 25% of post-acute patients discharged from hospitals go back in the first 30 days with regards to a Medicare population. So how does that work? One of the primary reasons for people being readmitted is falls. Let's discuss that. Let's say a client, a homebound client, 87 years old, walks around with a straight cane, has fallen 2 or 3 times, hurt herself on the 3rd or 4th fall, went back into the hospital, or went into the hospital, was discharged home to home care. Is the home care clinician or therapist going to be able to get her to use a walker while we see if she can get strong enough to use the cane, or are we going to lag behind programming and acquiesce to the patient's statement that she doesn't want to use a walker and continue to risk the hospital readmission upon walking with a cane? So these are specific clinical approach and programming nuances that will spell the difference. And this certainly involves communication with therapists and nurses to help rewire this care approach. So how will or can you contribute? And the programs that you're going to need to deliver are going to need to solve problems for the ACO, which means how can you get patients better, faster for the ACO than we have? And that's the key. It's not about the same things as we've always had. It's about setting up care to find who's better and giving them the patients. And that's why you want to focus on now. Now we're going to talk about the provider requirements for participants in our ACO bundling model at the DMC. First of all, we have significant reporting requirements. It doesn't matter that a doctor in the system wanted us to use this agency. It doesn't matter that the agency has seen many of the patients for a number of years. It doesn't matter that the agency has the best outcome scores or the lowest decreased readmissions. And nonetheless, we have reporting requirements because this is going to be managed by the hospital system the way they manage DRGs and hospital admissions over the past 30 years. First, financial disclosures. Because by assigning post-acute ACO patients or bundled patients to nursing homes and home care agencies and inpatient rehab floors, the hospital or health system will be effectively partnering with those post-acute providers in a financial realm. If the post-acute providers deliver inefficient services and run the costs of Medicare delivery up, the hospital will suffer the financial losses of those. They are partners. So therefore, financial disclosures are required, and a number of our eventual vendor partner roster providers literally had to be threatened with being removed from the vendor roster in order to provide the financial disclosures. So you can see this is more than a wink and a smile to become involved here. Clinical parameters and protocols will be necessary. We're not hoping that you can make this work. We are going to make sure, just as a hospital would, that our doctors are doing the things we want them to do, and our nurses are doing the things we want them to do, and our therapists are doing the things we want them to do, and that may or may not have relevance in today's home health world. Next, utilization review. If you have heard me speak anytime over the past 5 years, you have heard me talk about our utilization review program. It's called SEARCH, but it's just a UR program. It's a UR program which says we cannot expect our frontline nurses and our frontline therapists to come up with winning care programs on their own. They didn't do it in any other job. No other Medicare provider works this way. And I want to make sure that everybody listening understands this. If somebody in your office doesn't manage the care and utilize the data obtained by the start of care nurses or therapists or the evaluating nurses or therapists and manages your care plans, you might as well tune out right now, because you can't participate in these ACOs. Or even if you participate initially, you're going to be kicked off quite quickly. I will quote our hospital administrator for the Pioneer ACO grant that we work with in Detroit. If you do not do some sort of utilization review, you should leave the program right now. We are a hospital. We are used to managing our nurses, our therapists, and our physicians. If you're not willing to manage your clinicians in the same way, you will not be able to provide the results that we want. So I cannot overemphasize this to anybody. Somebody's going to call me after this and say, tell me how to get in an ACO, and it's not going to have taken 1 minute to think about how we're going to start utilization review for your care program. Now, you need to produce a savings approach. This is all about finding efficient care, again, based on wellness, so that we make care delivery a positive rather than something that distracts from the care. Innovative care management and delivery. Who can find ways to get people better faster? We're going to talk a little bit about this and some of the nuances that we're starting to develop in other ACOs that are literally Pioneer ACO grants, but are ahead of the curve a little bit on this. And then we'll have to examine therapy philosophies and concerns, because many of those exist with regards to the ACO grant when you look at the PPS era under home health. So what are the provider requirements for the reporting? Well, number one, we want to know your adverse events, and not just your adverse events today, but your adverse events across the last couple of years. We want to see what your legacy of patient protection is. Are people falling? Are your patients falling? Do you have med management errors? Because these are the things that put people back into the hospitals. And this is just the first wave of what ACOs understand about what they're going to need to produce in the community and what they're going to need to manage for the community. It's important to understand that right now they look at this. Of course they want to pay attention to adverse events. Of course they want to pay attention to med management errors. Of course they want to pay attention to falls. But eventually they're going to start to understand things about the post-acute community that we might understand a little bit better than they do now. They might understand that patients with UTIs fall more. And they might understand that patients who time void have less incontinence and therefore less UTIs. And they might expect a home health provider to receive a hospital discharge of a patient that's had a UTI and a fall to innately initiate time voiding upon start of cares. So you're going to want to see that these management items start to come home to roost. What do we have here, and how are we going to treat it? And that is really what UR program set up to start with. So falls, when do they occur? What is our response? And what are we able to do to prevent? So if you're thinking, well, they occur when they occur, and our response is to write an incident report and call the doctor, and our prevention is to focus on the fall risk prevention approaches, you may or may not be solving these problems, because we're going to make sure that we understand that fall risk is really not the approach of choice, especially the fall risk assessments the way they've been utilized over the past 3 or 4 years, especially those that indicted the 3 largest home health providers with regards to overutilizing the therapy component, all based on fall risk assessments and programs. So you're going to have to step correct and carefully in those areas. Now, they're going to want readmission statistics for you, not just what your percentage is, and they're going to compare that against your home care compare, but they want readmissions based on diagnoses. What is your readmission rates per diagnosis, especially those diagnoses that they're thinking about sending to you under the ACO model. Next, survey results and accreditation. They're going to be asking for reporting on this. I will tell you, I want to make sure everybody understands this, there's very few requirements about accreditation. They don't have a survey result idea in mind. They just want to see how you do in those areas. You can have great survey results and great accreditation. If you can't manage these other areas, you're not going to be getting their patients. So there's a number of different checkpoints that you have to start to address. Clinical programs. How do you develop them? How do you deliver them? How do you manage them? How do you end them? Are they volume-based? Certainly, if you are evaluating 2 home care providers for your post-acute patients, and one home care provider has seen your post-acute patients over the past year, and this home care provider has averaged a 9-week length of stay. And another home care provider that has your patients over the past year has averaged a 22-day length of stay. Who do you think is more likely to be able to manage your patients in the first 30 days? The agency that's been used to 9 weeks, or the agencies that's been used to resolving problems in 22 days? And then last, and I would not understate this, is your ability to use ancillary providers associated with the ACO. If the ACO has a DME, and most ACOs will, and your patient needs equipment, guess who you're going to have to get your patient equipment from? And if you send them to the equipment companies you traditionally use or maybe have some professional relationship with, the ACO is not going to want to send money to them. They want to send money to their own affiliated DME. If you need lab, emergency room, portable x-ray, et cetera, all of these will need to be shuttled back into the ACO if you want to participate on the ACO team. And you can start to see it's going to be so much less simple than getting a referral and assigning clinicians. You're going to have to manage this at each and every turn, and you're going to have to manage your proposals to participate in this team. The ACOs, where do we start? Well, if you want to really take a look at how to start to move towards an ACO, you need to first examine your post-acute caseload. Which patients do you get that just came from a facility? Hospital, inpatient rehab, skilled nursing facility, long-term acute care hospital. These patients that come to you are going to be the post-acute bundled patients of the future. So which patients do you get now from these facilities? Because they will be being approached by ACOs, and if you get patients from these facilities, you can be a part of that conversation. That is where you start today. What hospital sends the patient to the SNFs that you get referrals from? What inpatient rehab floors send you patient referrals? Does the hospital and the inpatient rehab floors send patients to the SNF that could go to home care in the future? These are the questions. These are the marketing opportunities. It's not going to be about physicians' offices unless those physician offices currently send you post-acute patients. So you need to analyze your referral forces. Exactly where do these referrals come from? Why do they come from there? And how do they come from there? Do they come from there because your marketer is the sister-in-law for the business manager for the physician's practice? Or do they come to you because your therapists have seen the patients for years and they always do a good job? Do they come from you because they know your nursing staff and your nursing staff is responsive? Or do they come from you because your marketers buy good lunches for the physician's office? Because those issues are going to cast a shadow on how you are able to manage those referral forces today or in the future. It's important to understand why you get the patients now and whether that motivation to deliver you patients will still exist in the ACO model in the future. Next, you can look towards MD groups that see patients in hospitals, systems, and SNFs, because these MD groups will be being approached by the ACOs for bundling savings. If you are an agency or a provider that's willing to work with a doctor to produce bundled savings, which means wrangling with your clinicians to provide contemporary and progressive care, which is not what we always see in home care programs, then you could conceivably be in a position to start with that. If you don't have MD groups that work in hospital systems or SNFs, you might just have MD groups that refer to you. Keep in mind that eventually those community referrals will be primary care ACO patients, and they will have home care co-payments attached to the fact that they were not discharged from an acute facility. So look inward next. Once you understand those elements that we've discussed up until now, I cannot think of an agency. I want to be very specific about this. I have been in literally hundreds of agencies over the past couple of years in nearly every state in the country, all types of agencies, small, large, for-profit, not-for-profit, health system-based, hospital-based, VNAs, you name it. And I have not seen the agency, maybe one or two, that is prepared for this model. So you need to look inward to your care management and delivery. How do you produce, manage, and deliver care? Are you efficient? Are you trying to decrease utilization based on patient response? Are you paying attention to the acuity? Are you assuring that the OASIS is correct and that you're using the OASIS to determine the care plan that you're producing and starting your home programs off of? And that specifically revolves around both nursing and therapy communication. And that is something that's going to increase wildly under the ACO model. Stop and think about what we're going to talk about. Nursing. When these patients used to be in the hospital, a nurse spoke to another nurse about them at least every 12 hours at shift change. And in addition to that, there were supervisory nurses and QA and UR nurses reading the notes on a contemporary manner. Oftentimes, that is entirely absent in today's home care setting. And we will talk to the nurse about it when we get to case conference. And I cannot tell you how drastically different this model will require. It's going to require communication about nursing, start of care production, and in-episode delivery that's going to mirror the types of things we see in acute care hospitals. I just want to ask everybody listening, are your start of care nurses calling your agency from the home during the start of care visit in front of the patient to collaborate on the care plan production? You know the answer to that. The answer to that is no. Well, that's the kind of thing that we're doing to help get people prepared for the future. You're going to need to do clinical assessment, clinical analysis, and then deliver clinical performance that matches those two things. So the kind of areas that we find when we work with providers in the home health industry where we have lapses about this is, number one, the clinical assessment. We have some of the best OASIS education available, yet the OASIS is rarely accurate, especially in the programming areas. We can't even get the F scores to be defendable and interreliable. And that's one of the most important elements of the OASIS. So we look at the OASIS visit and the start of care visit in this manner. It's up to the start of care clinician to go and obtain relevant and focused and accurate data. We then owe the start of care clinician assistance in creating a care plan, if not entire oversight or relinquishing of them of that responsibility. How do we make sure that the care plan they put together matches the OASIS we turned into Medicare? In order to do that, it's all about clinical assessment. And then we analyze that data in order to produce a start of care care plan. And then how are we assuring that from clinician to clinician, week to week, that we perform that care plan in a progressive and assertive manner with an entire focus on readmission within the first 30 days. And if you're thinking, well, we're going to have to make a lot more visits in the first 30 days, I think you're thinking on the wrong path. Because if it was just our presence there that kept them from going to the hospital, they probably need a sniff. We need to make things happen in the home that can keep them from going back to the hospital. So continuing on, how do you start? Utilization review, when and how. At the start of care visit by your QA or your UR nurse. If your nurses are calling or your therapists are not calling from the start of care visit to the home, a lot of agencies are starting to do that now. I think you'll all be doing that in some way, shape, or form in 5 to 10 years. I do not think that we'll be creating care plans in the community with frontline clinical staff members. So second is clinical staff. Can you control your staff? Can you make sure that the staff has correct OASIS data? If you're working with them on the OASIS data and it's clearly wrong, are they telling you that they're not going to change it? Let me just ask a question that's really been coming home to roost with me lately. Can a provider, meaning a hospital or a nursing home or an inpatient rehab floor, can they decide what their clinical staff is going to provide to their patients? I think they can. In a hospital, They certainly decide for the doctor that the patient needs to leave now because we don't have any reason to keep them here. They often decide for a doctor you can't use a PICC line to provide or to draw labs from. In Michigan, you can't use a PICC line to draw labs. You can only use a PICC line to deliver medications. So you can see that the clinical staff at the physician level is managed by the hospital. How about the nurse? Does the nurse get sent home if the caseload goes down and the census doesn't support the nursing staffing and have to use PTO? Certainly she does. How about the therapist? Can they tell a therapist to go upstairs and teach the patient how to use crutches because then they're going home afterwards without the therapist saying, well, wait a minute, you can't tell me to teach them how to use crutches. I'm the therapist. You're not a therapist. I'm the therapist. Certainly they do. Therapists go up and teach them how to use the crutches and the patients go home. So clearly providers can control their clinical staff. What about in an inpatient rehab floor? If the OT says they only want to do 20 minutes today and the patient doesn't have 3 hours worth of care so they can't admit to an inpatient rehab floor, certainly the providers can control their clinical staff. There is not a physical therapist who has ordered a 3-time-a-week frequency for a Part A patient in a skilled nursing facility in America because you need to have 5 times a week services in order to provide Part A coverage in a SNF. So clearly the providers can control their clinical staff. That's not always our scenario in home care. We take the clinicians manage their own productivity based on the missed visits that they take. Oftentimes they control their schedule, and oftentimes their documentation is not timely, which we'll talk about next, and that the care is approached with a hands-off perspective to the provider because you're not the clinician and you didn't see the patient, or whatever one of the responses that we hear traditionally are. So I cannot overemphasize to you the importance of you understanding if you cannot control your clinical staff, you are going to be out of the industry eventually. Timely documentation. You're going to need to write your notes. If nothing else today, you're going to need to write your notes or have your clinicians write the notes when they actually treat the patient, which is wildly different from our history in home care. And then productivity. I just remember an agency owner saying this to me a couple years ago. He couldn't have been more right. If you want to control your staff, you need to control their schedule and their productivity. And that means that they've got to make sure that you understand exactly how you're managing your clinicians, just the same as you may have had those clinicians managed in an acute care facility. Something that we're talking about for ACOs now that I think is a new concept for home care, wildly new concept for home care. I run into it at almost every agency, is fresh staffing. If we want to provide efficient care programs, if we want to keep programs, clinicians, and patients fresh, we need to stop providing the requested staffing from the patients or the caregivers. I had Amy, she was my PT last time, I want her again. I had Linda, she's my nurse, she's always my nurse, I want Linda as my nurse. That short sheets the patient clinically in many instances. The clinician is overly familiar with the patient. Because of the friendly nature, the clinician may or may not provide the most efficient care program. If you called me and asked me to come work with your agency, one of the first rules I would tell you is to resist and refuse to provide identical staffing in different episodes, because the care programs are not clean. They're just not clean. I mean, I was talking to a physical therapist a couple of weeks ago who didn't want to see a 91-year-old who she had seen as a patient numerous times in the past because she had seen him walk in the community a week earlier. And since that time, the 91-year-old had a pulmonary embolism and was hospitalized. This is the kind of demeanor we're begging clinicians to see these patients, and that is a result of not insisting upon fresh staffing. Hospitals do this. Hospitals change your nurse almost every day so that you don't have the same nurse 2 days in a row, so they make sure that they keep it efficient and clean. And you may want to spend some time pondering these items. Weekly rounds versus the case conference. We don't have 17 to 21 days to get the group together to decide whether we were efficient or not. You're going to need to start managing your clinicians the same way that other more acute providers do by providing weekly rounds of all your clinicians. Identify keepers in the new care models, and by keepers I'm talking about clinicians. It's a different page that we're going to be working on. Some people understand it, like it, and understand the logic of where we're headed. So identify those people as you move through. There are going to be some that aren't keepers, and you should identify those as well. You need to understand, if you're going to move forward and you're going to work with an ACO, you need to make it work. You need to make it happen. And most likely that will be clinically or in the area of clinical management. So before we move on from ACOs to bundling, we want to talk about miscellaneous items about ACOs. Post-acute providers certainly could service multiple ACOs. If you're a home health agency that's really good at getting total knee replacements better and under 5.2 visits, guess who they want? They want you. And guess what every ACO is going to want? They want you. Eventually, you'll be posting hospital and health system and ACO profit margins, and the ones with the clinical management skills are going to post the high profit margins, and they're going to be asking, who do you use? And I think that's important for you to move forward along those lines to make sure that that works for the ACOs, and you're going to be able to work with multiple of them. CMS will still have you doing direct billing initially. You'll be signing confidentiality agreements to make sure that what types of protocols you're putting together in the ACOs and the bundling models will be not distributed amongst the industry. So you can see how this is more than a benchmark, let's all share our protocols approach than what we've had today. Literally, this is the opposite of what we do today. Today, our clinicians look for other reasons to help the patient. You'll be focusing on the post-acute reasons. Today, our clinicians, again, I think I gave you an example, may take 4 visits to teach 4 caregivers, and in the future, they may congregate those caregivers on 1 visit. Today, we might be forced to accept missed visits. In the future, we'll be calling the ACO and saying they won't let us see them in the community. So we want to make sure you understand that there are many areas that we need to start to ponder exactly how we do what we do today. Unmanaged therapy breaks bundles. I hear comments all the time about the contract nature of therapy. TAC has asked me to come down and speak at the winter conference, and they say because most agencies in Texas have contract therapists, the therapists come in and change the F scores and say they're not right, so after we see them for 60 days, the patient looks worse than when we started them, and so on and so forth. All of that is the result of not managing your therapy. And we've all looked at the contract therapy components here, and we've all said, oh, we're held hostage by the therapist. Well, you're going to have to figure a way to get out of that, because that's not going to work for you, and you're going to lose patients. And I've managed therapists for 30 years. I think I pointed out to you that about 10 years ago, a hospital-based VNA laid off 30 therapists and gave me the contract because I could manage them. So it is doable, and it is doable with contractors. I'm a 30-year therapy contractor for Homecare. I've never been employed, never had W-2 taxes taken out of a check. So nobody cares that they're therapy contractors except you and the therapist. They're still your therapist. And the term contractor is nothing other than an IRS term that talks about whether they're 1099 contractors or whether you take taxes out of them. They are still exactly the same clinical team member that they would be if they were employed. So you need to call your therapy contractors in and have a come to Jesus meeting about these sort of philosophical elements if you expect to make this work. Otherwise, you can just really stop thinking about ACOs, because I will tell you, the therapy is at least an equal amount of focus on the post-acute care management model as nursing is. So your clinical content, can you control it, and can you control the philosophies of how your clinicians work? Last, don't let patient choice fool you. Patients have choices to use their providers, but this is going to be different than what you think. Today, because of the lack of control in episode lengths in the home health industry, you think that when a patient chooses a home health provider that they're actually choosing their utilization. And I think that's exactly what you're going to see go away. Sure, they can choose your agency, but your agency is not going to be able to give them 12 visits for a total knee replacement when the bundled agency is going to give them 5.2. The doctor's going to lose the gain sharing. Nobody wants to be a patient for 12 visits when they can be a patient for 5 visits, and you're wasting unnecessary health care expenditures. So the fact that the patient can choose you, don't let that fool you. You're going to need to make these changes and these adjustments in order to deliver the care content of the future. As we move on forward with this, we're going to focus a little bit more on the readmission element, the post-acute bundling. This is what we're just awarded the Model 2 bundling demonstration pilot for at the DMC. And this is based on many of the concepts that I've just been talking to you about. These items that I'm talking to you about are the parameters of our Model 2 bundling program. And basically, it is a program that is titled Payment for Care Improvement. And I want to focus on one specific word here, care improvement. So if you're wondering how you're going to participate in the ACO world, I would ask you, I wouldn't really be concerned if you have today's post-acute patients. I would ask you, how are you planning to improve your care? Because, listen, I've given you half a dozen ideas in the past 40 minutes. I think that you need to be conscientious of that. Things are changing, and we need to improve the care. I thought in the last webinar I talked to you about Bill Dombey's comments about how you should be preparing for the future. That's what this is about. So don't take today's role in post-acute and presume that that's going to help you into the future of the bundling model. It is something you have to go out and do and make happen. So they're going to choose a care model on a per-patient basis. This patient has this problem, and that's why they need this care. This patient is almost identical to this patient, but they have this other issue that requires 4 more visits. Once we saw that patient, we realized we could resolve that other issue in 1 visit instead of 4 more visits, so we only gave them 1 visit more than the original care model required. That's the kind of conversation that you're going to have to be having. That's the kind of results that they're going to be looking for, and I think that's important for you to understand that that is a conversation you should and could be having with your start of cares that your agency performs today. So what are you doing to pay attention to these things? Because most of the readmissions in the first 30 days occur from med management errors or falls. How are we managing the meds? How are we getting it happened? How are we managing the meds in a way we weren't managing them last year at this time? How are we managing the falls? How are we addressing exactly what our therapists are doing? One of the things that utilization review provides for you, and I want to be very specific with this, you have heard me say this before to you at least a dozen times. My problem with therapy utilization is that we have physical therapists seeing safe ambulators just the same intensity as unsafe ambulators. The unsafe ambulator is 1 step away from a fall. How can we validate to the health system that we didn't treat them any differently than we did the patient who was unlikely to fall because we have a therapist that says that that's not what fits into his schedule? So that's what we're talking about. Lead your care. Lead your patients. Lead your doctors. And if you want to start thinking about how to do that, the PPS model is a good warm-up for that. That shows you exactly where the focus should be if you perform the OASIS correct and embrace the PPS model. Continuing on with post-acute bundling, therapy concerns, do you contract or employ? It doesn't really matter, but are you getting what you need from your therapy group? And let me just say this out loud so I can save you from saying it. Your therapy contractors or employees right now think they're giving you what you need. They are not giving you what you need, and the requirements are going to increase in the future. So your success will be based on your ability to educate, control, manage, and produce results from those therapy personnel. And it's going to, if you're not on the same page, you're going to struggle to do that. People will be doing that all over the country. If you think that the ACOs are going to be held up, and the bundling projects are going to be held up by therapy contractors, I got to laugh out loud about that. Hospitals have been managing physicians for 30 years. You really think they're worried about therapy contractors? Stop, please. This is what's going to be happening, and the faster that your therapy contractor can get on board with this, the faster they're going to be in a position to improve their private practice over the next decade. Start of cares, evals, care plans, and documentation. Can you manage all these? Because the ACO is not going to tolerate not managing this. Think about this. The ACO is a health system. They manage start of cares, admissions every day. They manage evaluations every day. They manage care plans. They don't let their frontline clinical staff put them together. And their documentation is never late in the hospital. It's just not. You don't leave until you do it. So when I go to agencies and hear that the nurses won't open their computers because they don't want to put the computer between the patient and the nurse, I openly laugh. You mean the same, between the same patient and the nurse, the same patient who just left the hospital and the nurse walks 4 feet from their bed out into the hallway and started charting on the computer attached to the wall? We just need to really take a look at some of these elements. What is our connection to acuity-based care? Do the patients who have the illness get the attention, or do the patients who are the squeakiest wheels get the attention? It's important for us to understand that. In-episode rehab management, how do we make sure that the therapy staff, especially the contract therapy staff, is not wasting time, content, or acuity in their care delivery? And questions regarding provider control really come home to roost. We've been talking about those all afternoon. So you need to get on the same page with rehab, and you should start now. I'm going to be talking to a private group of therapy contractors this weekend in Dallas that all use the same software, and I'm going to be encouraging them to call their providers. If you're not using one of those therapy contractors, you should probably think about calling your therapy contractor. So to finish, again, this is home health strategic management. I know we're throwing a lot of concepts, but they're going to keep coming fast and furious since we've been awarded the CMS bundling pilot. So I'm going to turn this back over to you, Andrew, and if you have any questions now, people could ask them. If not, they could email them, and you can email them back to me as you did last time.